Welcome back to the Clinical Lounge, everyone. Today, we are diving into a deformity that sounds like something straight out of a Jungle Book, but it is actually a profound marker of neurological dysfunction in the hand. We are talking about the Ape Hand Deformity. Dr. Sarah, I know you love the anatomical precision of this one, but to me, it is the ultimate great flattening of the palm.
It is a fascinating topic, Dr. Khan. While it sounds exotic, academically, it represents a classic high-yield board exam presentation of a median nerve lesion. Specifically, we are looking at the consequences of losing the thenar eminence. When the thumb loses its ability to oppose the other fingers, it essentially reverts to a more primitive, non-opposable state, hence the name ape hand. But for the students listening, the pathology is all about the recurrent branch of the median nerve.
Exactly, the recurrent branch. In the OR, we call it the $1,000,000 nerve. Why? Because if a surgeon accidentally nicks it during a carpal tunnel release, the patient loses their thumb function, and the surgeon loses their malpractice insurance. But why does this matter clinically to a general practitioner? Because the thumb is the CEO of the hand. If your thumb cannot touch your pinky, you have lost 50% of your hand's utility. Think about buttoning a shirt or picking up a single pill. Without that pincer grip, you are in real trouble.
Not as a great analogy. Let's break down the OAF mnemonic for the thenar muscles. These are the muscles located in that beefy mound at the base of your thumb. You have the opponent's pollicis, the abductor pollicis brevis, and the flexor pollicis brevis. All three are innervated by that recurrent branch of the median nerve. In an ape hand deformity, these muscles undergo severe atrophy. This is why the palm looks so flat. The meat of the thumb is literally wasting away.
It's like a balloon that has lost all its air. When you look at a patient's hand at rest, the thumb should naturally sit at a right angle to the palm, ready for action. But in a median nerve injury, the thumb falls back into the same plane as the rest of the fingers. It looks two-dimensional. Sarah, help the students out here. Why does the thumb move back into that specific plane?
That is a critical board exam point. The thumb is pulled back into the plane of the palm by the adductor pollicis. Now here's the catch. The adductor pollicis is actually innervated by the ulnar nerve, not the median. So when the median nerve is damaged, the OAF muscles quit the game, and the ulnar innervated adductor pollicis wins the tug of war, pulling the thumb flat against the side of the index finger. It is a rotation and adduction deformity.
It's a default setting. If the primary movers are out, the backup muscle takes over and pulls it out of alignment. Now, let's talk about testing this. Why does this matter clinically when you are sitting in a busy emergency department? You have to be able to spot this quickly. I always use the pen test. Have the patient lay their hand flat on a table, palm up, and try to touch a pen held just above their thumb. If they can't lift that thumb vertically to meet the pen, you are looking at abductor pollicis brevis failure.
And remember to distinguish this from the hand of benediction. Students often mix these up. Ape hand is a static deformity. It's what you see when the hand is just sitting there due to muscle wasting. The hand of benediction is a dynamic sign. It only appears when you ask the patient to make a fist. If they have a high median nerve lesion at the elbow, the index and middle fingers will not flex, creating that blessing gesture. But the flat palm of the ape hand, that's constant once the atrophy sets in.
That is a vital distinction. One is about what the hand looks like, and the other is about what it can do. When patients come in to see their doctor of choice for hand pain, they might only complain of numbness in their first 3 fingers, but as a clinician, you are looking for that sunken-in look of the thenar eminence. If you see that wasting, the clock is ticking, because the nerve damage is transitioning from irritation to actual axonal death. Clinically, we also have to consider the location of the lesion. A low lesion at the wrist, like a deep laceration or severe carpal tunnel, will cause the ape hand because it hits that recurrent branch directly. A high lesion, like a supracondylar fracture of the humerus, will cause the ape hand plus a loss of the long flexors in the forearm. Either way, the loss of opposition is the functional disaster here. It really is a disaster. If you can't oppose, you can't grasp. You're left with a claw that can't hold a coffee cup. I always tell my students to think of the thumb as the pincer. If the pincer is broken, the hand is just a paddle. Sarah, let's summarize the high-yield takeaways for everyone before we sign off.
Absolutely. For the boards, 1. Ape hand is caused by a median nerve lesion. 2. It involves atrophy of the thenar muscles, specifically the opponent's pollicis, abductor pollicis brevis, and flexor pollicis brevis. 3. The hallmark is the loss of thumb opposition and a flattened palmar appearance because the thumb is pulled into the plane of the fingers by the ulnar innervated adductor pollicis. And my clinical pearl, always check the beefiness of the thumb base. If it looks hollow, think median nerve. And remember that opposition is the most human thing our hands do. Don't let your patients lose it. Thanks for a great session, Dr. Sarah.
Anytime, Dr. Khan.
See you all next time.